Thank you for joining on a early and at least in Dayton, Ohio, very rainy morning. Yeah, it was a really interesting mix of folks today. So happy to be here. I have a number of different hats, as most of us in the substance use space do, especially those of us in education. I am the program director of the Addiction Medicine Fellowship at Wright State University. We have been accredited since 2022, but have our first fellows graduating this year. I also have a consulting role with Premier Health, which is a large health system here in Dayton, Ohio, where primarily we're looking at the structure and policies and order sets and sort of making it easier for our non-addiction specialty physicians to care for this population. And I think most pertinent to this group, I've been the medical director of Women's Recovery Center in Xenia, Ohio, which is a rural suburb here of Dayton, and that has been in place since the 1980s. And we take all persons who identify as women, including those who are pregnant, and then we also care for persons in our 3-5 program who come back after delivery or have young kiddos at home. So it allows people to access treatment without having to decide or manage the challenges of parenting, as sometimes many of them tend to be single parents. So that's me. So I'll go ahead and get started if that's all right with you, John. Is that where
It
we're going
is.
next?
Yes, it is.
All right, great. Um, well, that's screwy. I can't see you guys when I'm switching my slides. So if you say something, I'll hear it, but I can't see the people. So in any case, so we're going to talk a little bit about pregnancy and the way that it manifests with substance use, particularly opioid use in the current day. And then I really set this up as walking through the perinatal period. So just highlighting some of the pieces during the perinatal period as we walk through that at some points of discussion, which I'll figure out since I can't see you guys at the moment. Wow. Okay. Um, things are getting screwy on my end from tech, but we'll just keep rolling. So one of the things that we've all heard in the news the last couple of years is that the rates of overdose deaths had increased, particularly during COVID. And And then in this year, we had a number of news articles that said, yeah, we finally have made a dent in those. They're coming back down. But if you look at, there were a couple studies that were published this year that's sort of interesting. If you look at the trend line, it's a net positive trend line that we're continuing to have overdose deaths in this country. But we sort of had this blip, this upward blip during COVID. And we've now reverted back to the pre-COVID trend line. So we have seen a decrease in overdose deaths. For the last couple, compared to the last couple of years, but if we look at the overall trend since the early 2000s to now, we continue to have this sort of gentle upward slope. And when we think about that, I think one of the things that's important as specialists in substance use is that that doesn't affect all persons equally. So we know that when we are talking about pregnancy in the peripartum period, that the overdose deaths in that period have not dramatically changed. We have not made an impact on this particular cohort or population. And that's true for another population as well, which is middle-aged and older African-American men. We are considering or continuing to see a rise in that population. So continued work to do in both of these areas fairly substantially. And when we think about treatment in the care of pregnancy for folks that have general substance use and substance use disorders, I think we all sort of know this, that there's a significant discrepancy in access to care depending on where someone is geographically. And then there's a significant variation in evidence-based care in this population. If you look at when you compare it to diabetes, for example, the rates of evidence-based care in this group is substantially lower. And as I discussed health inequities on the previous slide, we have continued health inequities in the peripartum period as well. So the rates of folks that are offered medication, and then when offered medication, the doses of those medications show significant differences. In listening to you all kind of present who you are and where you're from, I certainly feel like I'm speaking to the choir. So I'm going to bring this up as not a reminder for you, but perhaps as a reminder for your teams. And I say this, I've been practicing in the perinatal space, substance use disorders in the perinatal space since 2012. And I would say that probably once a year, less so now, but every couple of years maybe, I have a scenario where now I practice family medicine, I'm a full spectrum family medicine physician, and I have learners and MAs and RNs, all sorts as part of our team. And I would say every couple of years we have a situation where someone comes into our office, requests a pregnancy test, the pregnancy test is positive, and someone enters that room and says some variation of congratulations in a really sort of exuberant way. And I would say in this population, we focus on sort of training our staff to address that differently. As many of you know, pregnancy in the perinatal period, particularly those that are actively using substances, the data say about 85% are unintended. And so this can be a really tumultuous time. Many of these individuals have had previous children removed from the home, and so have significant trauma related to that. So I always encourage when I'm working with staff or students, or a nice reminder for ourselves, that when a pregnancy test is positive, to really be truly neutral in our language and body language, and to say things that are fairly objective, something to the effect of, your pregnancy test today was positive. How do you feel about that? And really giving a lot of space to allow the person to react. And as I share with students, I'd say most of the time that first visit is really allowing the reaction and processing. And then if you get to it, sometimes talking about what prenatal care looks like in the context of substance use, what options may be available, including elective termination, adoption out, or parenting, and just also supporting that they may not know at that point in time what their decisions are. But I'd say vast majority of the time, that first visit is really, really focused on processing. Going to move through this slide kind of quickly, but just to highlight that, we sometimes think of screening for substance use in pregnancy as a sort of afterthought in the context of pregnancy, at least in the general perinatal world. But when we look at its rates compared to other diseases that we do tend to really focus on in the perinatal period, it certainly is equivalent, if not higher than those. This could be a whole discussion on its own, is the role of screening and biologic testing in the perinatal period. But to sort of simplify it and say a couple of things about that. One is that, both ACOG, ASAN, multiple different national organizations call out that we really should be doing these evidence-based screening tests for substance use or substance use disorder in pregnancy, that we should not be depending on biologic, particularly urine drug testing, to do that screening for us. And I think, when I think about my consultant role for Premier, that is something that we highlight kind of time and time again. So something that really is needed to be kind of echoed out in our communities. And the reason for that is manyfold, but I think, this is a pretty complex slide, but I'm going to walk through it for you all. We know that screening tests, you want to have a screening test that picks up a positivity and then move on to a diagnostic test. And for a number of reasons in this space, that doesn't always play out. And one of the reasons is there's an assumption in the general medical community that these screening tests are pretty accurate, which is not true for screening tests in general, and absolutely not true for these particular screening tests. And the other part of that is the cost, the cost of a confirmatory and the time of a confirmatory test. In my community, it's 7 days, usually 3 to 7, but more likely 7. And the cost is substantial, $800 sort of dollars range for these confirmatory tests. But one of the reasons that we don't recommend just universal urine screening is sort of this. So we know that this bottom line here on both sides, that we know that about 15% of persons are using substances during pregnancy. And we know the positive and negative rates of these particular tests. And so if you look at this, if someone doesn't have substance use, they can have a positive test, 43 people out of your 1,000, and that could be a very busy labor and delivery, or that could be a, suburban or rural hospital, maybe, every 3 months or every 4 months. 43 of those people are going to have a positive test and not have a substance use or substance use disorder. And in some communities, we're seeing these screening tests sent on to the courts or to children's services and causing all kinds of havoc. So all this to say that a couple of boundaries when I'm teaching learners is, there's some firm boundaries in most things that we do, and there's a lot of things that are reasonable. When we're talking about urine drug testing in the perinatal period, I would say some boundaries are that we should be doing these evidence-based verbal tests. Another boundary is if you're going to act on a test, it should be a confirmatory test. And another third boundary, I think just as important, is that if you're going to be doing urine testing, specifically urine biologic testing, you absolutely need to get consent. And I'd say that last part is pretty variable because we're often getting urines for lots of other reasons in the perinatal period and often just kind of send this off. And that's certainly problematic. I was a part of OPQC in Ohio Perinatal Quality Collaborative, and I'm sure many of you also are. This is not one of the current focus areas, but a couple of years ago was a focus area for OPQC. You may see my dog walk through that. But just to say they have a really wonderful model of how to have obstetrical prenatal evidence-based care and substance use care in parallel, and exactly what those look like through the course of the prenatal period, if that's something that would benefit your team. Okay, let's see if I can figure out how to get back to you guys. But I want to have a brief kind of open mic. So when we think about MOUD, particularly agonist medications for MOUD, why do we use those in the perinatal period versus just abstinence when we know that these can increase the rates of NOWs? And I am going to figure out how to get back to you guys just a second. All right. Feel free to unmic if you want to talk about why we use these medications.
Does anyone have some thoughts on the question?
Well, I mean, if they're using street drugs or prescription drugs or, non-prescribed drugs, I mean, part of it is for morbidity and mortality for the child. If we're just talking about the safety of the mother itself, obviously overdose and relapses and all those things. So trying to keep her safe as well.
Yeah, and you say that it's like, yeah, this is obvious, and I think that in this group, it certainly it can be, but I don't know that that's true in all groups that this information is shared. Great. What else?
From a non-physician, I'm just going to share what my understanding has been and to kind of check in to see if this is accurate or not, because I do want to leave with accurate information. I've understood that putting somebody on an MOUD at least offers them some consistency in dose and intensity over time, without the risk of sudden discontinuation. Where with active street use, there's a lot of vacillation in the amount of in the dose and intensity and potential withdrawal. So, like I said, I'm not sure how accurate that is, but there's greater minds than me here that can verify if my understanding is on point or not.
And I just want to add to John's, I mean, the potential presence of unintended substances, if they are using products that are obtained illicitly, may not even be anything that anyone is aware is in there that they would unintentionally be exposing themselves in the developing baby.
GYNs I would work with wanted the patients to be on something that they would be on the whole pregnancy as opposed to going and getting something off the street and possibly putting themselves and a baby at risk.
And also just keeping the person engaged. A lot of these people have very little prenatal care, if any at all.
Yeah, we know prenatal care is important, right? And so it's important for all populations, very much including this population. How do we get folks engaged in healthcare that they feel safe? I'm trying to get back to sharing and see what I can see. Oh, I can see you guys now. Not sure what the difference is. That's fantastic. Yeah, so we talk about the Katalchik index, which is a fancy word to say increased rates of general prenatal care. We talked a little bit about the risk to the dyad, and that certainly includes things like infections, HIV, hepatitis, sexually transmitted infections, risk of intimate partner violence or other physical harm, certainly risk of unintentional overdose. So lots of reasons to be on MOUD in pregnancy. And I guess I would highlight here, one of the things that we talk about in pregnancy, in the perinatal period, in substance use and in general, is sort of this risk discussion, right? So what are the risks of intervention and what are the risks of not? And I think that this highlights that consideration very well. So just to say, in the general perinatal period, using medications like methadone, or more specifically often buprenorphine, for assisted withdrawal is not appropriate in pregnancy. That's called out in the literature. In general, both buprenorphine and methadone are considered equally safe, and it can really depend on the person's individual preferences and access to both of those medications. We're going to talk briefly about breastfeeding in pregnancy. That's changed fairly abruptly in the last couple of years, the guidelines around that, which are beneficial to our diets, and that we should be thinking about harm reduction in the perinatal period as well. So for me, I was practicing substance use treatment in the perinatal space prior to the mother study. This was really a study that came out that said, yes, buprenorphine is non-inferior to methadone. In doing the work that I was doing during residency, it was a big part of a perinatal opioid use treatment practice. And we were sort of seeing this edgy, or depending on who you're talking to, maybe a cowboy. But this study really kind of came out and said, no, this is not inferior to methadone, and may and likely now has been fairly substantiated that it probably has less opioid withdrawal risk that requires medications for that newborn. So really, it is equivalent and should be based on patient preference. The other thing that I sort of think about, and when we think about MOUD options and walking through those choices with a patient, I'd say in pregnancy, it's a little bit unique. So I usually think about it in two ways. Is this a person that is pregnant and new to treatment for their opioid use disorders? Or is this a person that was stable on treatment with opioid use disorder who now happens to be pregnant? So there's two sort of different groups when we're thinking about that. And when it's a new person to treatment for MOUD and is pregnant, we really do sort of prefer buprenorphine and methadone, and really the sublingual buprenorphine. I'll talk about that a bit. But when we're thinking about someone that is very stable on an MOUD, we might have a risk discussion regarding naltrexone, or we might have a risk discussion regarding some of the long-acting buprenorphine. Regarding naltrexone, there's increasing studies on that because of the benefits. There's not an opioid withdrawal syndrome related to naltrexone. There's a number of case reports in a retrospective review article that says the gestational age at birth related to naltrexone is similar without the opioid withdrawal. For me, as a perinatal provider, I think what I haven't seen in the literature is how we address in a patient-centered way those considerations when something goes sideways in pregnancy. So there's a number of review articles and case review articles. For example, I read one yesterday in preparation for a journal club for my fellows talking about this. And all of them were full-term vaginal deliveries. And I work at a tertiary care center where I think most of our deliveries are not full-term vaginal deliveries. And so just how do you manage pain, especially complex post-operative complicated surgeries, if someone has particularly IM or even naltrexone on board. And I think there are strategies to that, but just makes me much more cautious in considering those. And that is a medication. So more to come. When we started using, especially during the mother study, when we started using buprenorphine products in pregnancy, it really was Subutex, and that was based on the studies of the time. I would say now it's fairly well accepted that either Suboxone or Subutex is equivalent in pregnancy, and it should be based on patient preference. In Ohio, I know some folks are not from Ohio, but in Ohio, Subutex or buprenorphine for the Medicaid population requires prior authorization, and that can cause delays in getting the medication if they can't afford it at cost, and can be kind of frustrating. So I'd say the vast majority of my patients do choose to continue their Suboxone, but some that had used Subutex in a previous pregnancy may prefer that. So either is fine. Just talk to your patient. There's ongoing studies, and I'd say again, fairly well accepted as expert opinion, but ongoing studies to prove benefit that in the perinatal period that there's increased metabolism of methadone. And so we certainly see need for split dosing of methadone, so twice daily dosing, especially in the third trimester. In our community with high fentanyl, chronic fentanyl use, we are seeing doses of methadone, particularly in the third trimester, up near total dosing of 200 milligrams a day, sometimes even up to 300 milligrams a day, again in that third trimester. So if you're seeing that in your communities, that can be physiologic just by the rates of metabolism that happen again in that third trimester. Usually we would kind of consider getting folks back down to pre-pregnancy doses over about 6-8 weeks. I already talked about this, so I'm going to keep going. Long-acting buprenorphine. So there are increasing studies for long-acting buprenorphine in pregnancy, and certainly I've had increasing use of this over the last couple of years in my non-pregnant populations. A couple things are sort of important. So for the Sublocade version, the one that's subcutaneous, the incipient, the stuff that makes that like hard lump for folks, that is teratogenic in high doses in animal studies. So in general, that particular formulation is disrecommended in pregnancy. But again, if somebody is already stable on it, and certainly past organogenesis, you might think about that risk-based discussion and using that in the second half of pregnancy. And then the alternative agent, the Brixadi, is in an alcohol-based solution. It is a very small percentage of ethanol that is in that solution. And if you're treating with that, I saw equivalent numbers of something like less than 1/10 of one drink of alcohol, or one standardized drink of alcohol is the equivalent of getting Brixadi in pregnancy. So that is generally the preferred agent and the one that is utilized for many of these studies, and one that most of us reach for if someone's considering a long-acting in the pregnancy period. Switching to after the delivery, I want to talk a little bit about NOWS, and I think, again, many of us practice in this space and we know what NOWS is. There is some variation I've found, and so I practiced in Columbus and then 2 different health systems in Dayton. So there is some variation in working with different neonatology groups about the length of time that they want to observe that infant, and certainly the evaluation method of that infant, so the eat, sleep, console versus the Finnegan testing. Just to say briefly, Finnegan has slightly higher rates of infants requiring medication versus eat, sleep, console. And eat, sleep, console certainly has more engagement of the parents in that dyad, so some benefits there. But certainly want to include or engage in the non-medication options for treatment. Lots of skin-to-skin time, keeping that room kind of quiet and calm, encouraging breastfeeding. That has to start in that prenatal period. And then if you need agonist medications to treat the infant, lots of options. I'd say most in this area are either morphine or buprenorphine. Things that I address in the third trimester, again, I find coming up pretty regularly, is many patients will ask, can I wean down or wean off of my medication to decrease the risk of NOWS from the infant? And I generally disrecommend that for a couple of reasons. One, we know that the metabolism is increasing in the third trimester, both of methadone and buprenorphine products. And two, that a return to use is much more of a risk than the risk of NOWS in the infant. And then lastly, I'd say that we know that there's, and I've certainly seen through my career, that there's not a direct correlation between the dose of buprenorphine, for example, and the likelihood of needing medication for NOWS. I've seen babies that are exposed to 2 or 4 milligrams total daily dose of buprenorphine that do need medications. I've seen individuals that are on 24 milligrams of buprenorphine that don't. So we think there may be a genetic component that affects this. Certainly tobacco, comorbid tobacco use affects it, and certainly some mental health medications, specifically SSRIs or gabapentin, make it more likely to need medication. But there's not a direct, so you really should just treat the person and their cravings and their risk of return use instead of kind of thinking about dose specific. In Dayton, Ohio, we have luxury of Bridget's Path. So there are a couple places in the US where there are these ambulatory NOWS treatment communities. So you can discharge a dyad, day 1, day 2, whatever is appropriate for the postpartum period, to these ambulatory facilities. And then that dyad can be together during that kind of monitoring phase. That allows a lower cost of care. Certainly you're not in a NICU environment. Hospital environment, allows for the dyad to truly be together, at least in Bridget's Path. It is some partnerships with Children's Services to allow some stability and other things there. They can stay there for up to 3 months. And for Bridget Path, one of the big outcomes that we have is discharging that dyad together. So decreasing rates of family separation and decreasing the rates of infants going into the foster care system. There are some other places that are doing more rooming and care for medications for NOWS in the hospital. We are not in the Dayton area, so if that infant does need medication, we're separating generally and sending the infant to the NICU, which is loud and noisy and higher cost of care and really doesn't allow for the dyad to go through that period together. That really important bonding period. As I already mentioned, there's significant benefits to breastfeeding during the peripartum period for infants that's been exposed to opioids. And we should be encouraging that. That's from multiple organizations. And I would like to highlight that the breastfeeding guidelines have changed from the Academy of Breastfeeding Medicine. So this is a pretty big change, actually. It came out in 2023. I think many of us kind of started looking at it in 2024. Prior to this, the previous guidelines had said that a pregnant individual needed to not use substances for 30 days prior to delivery and preferred more than 90 days. So if you had a return to use or ongoing use in less than 30 days, you were discouraged from breastfeeding. And if it had been more than 90 days, you were encouraged to breastfeed. And then that grace period, it was kind of a patient-based collaborative decision. And that has changed. So now the recommendations is based on the folks that quit illicit substance use or non-prescribed substance use prior to that delivery. They really do have good outcomes for both breastfeeding initiation, sustainability, as well as their substance use recovery. And so that dyad should be encouraged breastfeeding. And that is a substantial change for many of our hospital systems and many of our neonatology colleagues. So I encourage you to share this with your team. In my role as a family doc, as well as my role as an addiction medicine specialist, I would say this is one of the most common questions that I get is how the heck do we treat pain in someone that is on MOUD? And sort of the easy way I describe it to folks is say, imagine you're treating a person that's not on MOUD and treat them exactly the same. So for the perinatal period, for example, a lot of my patients are in early recovery when they have a C-section. So I'd say for a C-section, generally we offer opioid-based therapy. Generally, we offer it for 3 to 5 to 7 days with non-opioid analgesia. And I would say that is exactly what we should do for our patients that are on MMD. So we would continue buprenorphine and offer opioids and offer non-opioid augmentation. And so this just walks through through a stepwise approach based on the severity of pain. And I want to be clear that we don't have to kind of fail each of the steps to move forward, except for that fourth one, or excuse me, that fifth one. That really you base it on how you would treat that physiologic pain in someone that was not under medication. For example, a severe sprain that you're seeing in the emergency department, you might just continue their buprenorphine and add, NSAIDs, Tylenol, topical, Voltaren, whatever that might be, versus somebody that's coming in as a motor vehicle accident with multiple long-bone fractures, whatever, someone that you would typically use opioids for, you would continue to use opioids in this population. I have rarely had to advise teams to stop buprenorphine and initiate only a full agonist, and that has generally been in some of the severe pain scenarios like severe third-degree burns, bad motor vehicle accidents. But that does cause some complexity, so generally we recommend keeping the MOUD on and treating on top of. And that is true in the perinatal period as well. All right. A couple more things to highlight, and I heard a number of folks who are family physicians on this call when I was kind of at that learning stage and deciding my future practice. I really went into obstetrics from a family medicine perspective to be able to care for that dyad. And I think that is critically important in this particular population. Whenever we think of individuals that are pregnant that have mental health disease, we are recommending close follow-up in 1 week and close follow-up in the office. And that is the same here for folks with a history of substance use disorders. For me, I currently practice at a residential treatment center and I do deliveries with the residents, but I don't have currently an ongoing prenatal practice. When I have, I generally see the dyad together. So you have infant visits, 1 week, 2 week, 4 week. I would see the postpartum individual at 1 week, 2 week, 4 week, and just make sure that kind of both are doing okay with parallel visits. It works very, very well. My staff are sort of used to it. But whatever your mechanism is, if you're just caring for the postpartum individual, then you certainly still need to create increased touch points with that person in that fourth trimester up to 12 weeks. In particular, thinking about touch points, talking about contraception during the prenatal portion, but absolutely during the delivery and in those postpartum cares, allowing folks to decide what works well for them and their future family planning. And lastly, I'm not going to go through all of harm reduction, but this is an amazing website, an amazing toolkit for thinking about harm reduction in the perinatal period. But a couple of things I do want to highlight for you all. Harm reduction absolutely is Narcan. In our community, we have a lot of fentanyl test strips. Utilizing those primarily for folks that are not primary opioid use preferred, but my folks that are in my rural areas and be more methadone or even sometimes cannabis or stimulant use. Buprenorphine itself can be considered harm reduction if you're continuing it during ongoing use in the perinatal period. It can prevent overdose and allow someone to continue in their journey while increasing engagement in care and decreasing illicit use. Thinking about safe use, whether it's safe use kits for intranasal use, safe use smoking kits, syringe distribution, and sometimes it's thinking about making a parenting plan before use. Who's going to be there with the infant or children during that period? So a very brief discussion of harm reduction. Again, it could be much more. These are my humans, and I love this photo, and I bring it up here to say that most of my job is exactly this. It's just kind of being there and supporting and telling people they're doing a great job. Talking to students and my teams about how important it is to create an environment that's inviting, so that folks, when they are kind of accessing our care, that they know it's a safe place to go to, and if it's not the right time for them, that they can come back at any time. So much of our job is exactly this, just sort of cheering folks on. So I'm going to step out of the slides and listen in a little bit of time that we have left, and comments or experiences that we have as a community caring for this important population.